Panelists, all the residents. I am Dr. Pranay from Trauma Center AIMS, and it's an honor to be presenting before MC Mishra sir here. I'll be briefly discussing about how to quickly do a systematic clinical examination of maxillofacial injuries in the ED. Now, any patient who comes with the history of trauma should be treated as per the guidelines of the 10th ATLS, and after a meticulous and rigorous primary survey only, a detailed survey of maxillofacial injuries should be done as it comes in the secondary survey. It is very important to complete the primary survey and address the issues arising from it. Now the maxillofacial examination can be broadly divided into extraoral and intraoral examination. In the extraoral examination, what we consists of inspection and palpation. What we inspect is, we inspect the scalp, eyes, ear and nose injuries, the middle 1/3 of the face and the lower 1/3 of the face, and we confirm the same with the palpatory findings. Similarly, in the intraoral examination, we inspect first the intraoral injuries and then confirm it with the palpation. These are the instruments we require. These are the basic instruments available in any ED, which we require for examination: gloves, nasal speculum, torch, otoscope, a tongue depressor, and a visual chart. Now, the extraoral examination begins with the examination of the scalp. We quickly examine the scalp with our gloved hands. We pass it through the hair of the patient and see if there is any blood or not. We also look simultaneously for depressed skull fractures. This photograph is showing a ecchymosis over the right mastoid, and it's known as a battle sign, and it is suggestive of a base of the skull fracture. Then we move on, after the scalp examination, we move on to the examination of the eye. We look on for any debris or any broken glass pieces. We look on for any eye laceration, eyelid laceration, which can be complete or partial, involving the canaliculi or without involvement of the canaliculi. For any corneal lacerations and tears, any circumorbital edema and ecchymosis. Like in the first picture, we can see a periorbital ecchymosis. It is known as raccoon eyes, suggestive of a head injury. We examine for all the gazes, which is suggestive of any to look if there is any rectus impingement with the floor of the eye socket fracture, and the visual acuity. So this is how we look for any rectus impingement. We see for if the movement is restricted laterally or in the upwards or downward direction. Now, after that, we have to look for the position of the globe, which has to be examined either from the head end or from the foot end. So we can see in this second clinical photograph that the second pupil of the second eyelid is behind that of the right side, and the patient has an enophthalmos, which suggests orbital fracture. And then, last but not the least, we have to look for the direct and indirect light reflexes. The indirect light reflex being more sensitive than the direct reflex to look for any optical nerve injury. After that, we move on to the ear examination. We look for lacerations, any bleeding from the external ear, CSF otoria, and tympanic membrane examination. After completing the ear examination, we move on to the nose examination. We look for any epistaxis, deviation and asymmetry of the nasal bridge, examination of the nasal septum, any surgical emphysema in the adjoining tissue, and CSF rhinorrhea. A CSF rhinorrhea fluid, when taken in a gauge, forms this halo sign, which is visible here. And this is the second clinical photograph is of a traumatic telecanthus in which the intercanthal distance has increased, and it is pathognomonic of nasoethmoidal complex injury. And the third clinical picture shows a saddle nose deformity, suggestive of a nasal bone fracture. Now, this picture shows a septal hematoma, which has developed and is being examined with the help of a nasal speculum. And then, after inspection of the nose, we move on to the palpation, in which we use our two hands to hold the root of the nose and the bridge of the nose, and we see if there is any abnormal movement is present or not. And this is the bimanual examination of the nose, in which we hold the root of the nose and use the artery forceps to see if there is any abnormal movement, to see if there is any nasoethmoidal injury. After completion of the nasal examination, we move on to the examination of the supraorbital ridge and zygomatic complex. So we palpate the supraorbital ridge, we are looking for any pain or any bony spurs and any crepitations. Here the patient is showing that he has a pain over the supraorbital ridge. And then we gradually come down to the zygomatic arch and to the inferior orbital ridge, looking for any bony spurs or any abnormal crepitations, movements and pain, and then to the zygomatic buttress. Now, after completion of the supraorbital, infraorbital and zygomatic arch examination, we come on to the examination of the mid-facial fractures, which has been classified by René Lefort in 1901 in 3 parts. The Lefort 1, in which the patient has a floating palate, in Lefort 2, in which the patient has a floating maxilla, and Lefort 3, which is a craniofacial dissociation. Now, these are the typical findings with which the patient with Lefort 2 and Lefort 3 fractures come in the ED. The first one is also known as a moon face or a panda face, in which ballooning of the face with circumorbital ecchymosis is seen. And the second is a dish face deformity, in which the height of the mid face is increased with subluxation of the mid face posteriorly and flattening of the facial features. Now, how to differentiate a Lefort fracture clinically in the ED? This is an examination of the patient with a panfacial trauma, in which the patient has Lefort 1 injury, in which we have stabilized the maxilla and we are trying to move the palate with the help of the upper tooth and see there is any abnormal movement. The palate is moving independent of the maxilla. So this patient has a Lefort 1 fracture. We'll increase the level of the, now we will hold the root of the nose and try to move the teeth to see. Now we can see that both the nose and the palate is moving. So the patient also has a Lefort 2 fracture. And then we move on to see if the patient has a Lefort 3 fracture. Now we hold the zygomatic frontal process of the zygoma, immobilize it, and then see the movement. The entire midface moves. So this patient has Lefort 1, Lefort 2 and Lefort 3 fractures. Now after examination of the mid-face, we move on to the examination of the lower 1/3 of the face, which is basically examination of the mandible. So we palpate the superior and inferior border of the mandible, the body, ramus, the angle of the mandible and the TMJ joint to see if there is any deformity, any bony spur or any abnormal movement present. This is a patient with a condylar, with a parasymphysis fracture, showing abnormal movement in the mandible. Now, the examination of the mandible ends with the examination of the TMJ, the temporomandibular joint, in which we ask the patient to open and close his mouth and move his jaw in left and right side, and we examine the TMJ laterally and posteriorly through the external auditory meatus. Here we can see that the patient is moving his jaw, but the movement cannot be palpated in the temporomandibular joint. So this patient has a subcondylar fracture. The transmission of the movement is not present in the TMJ. This completes the extraoral examination, and we move on to the intraoral examination, the inspection part, in which we see for mucosal lacerations, contusions, mouth opening, and ecchymosis. Like a sublingual ecchymosis is almost diagnostic of a mandible fracture and examination of a palate. We confirm the same with intraoral palpation for buccal, in the buccal and lingual sinuses. We look for tenderness, alteration in the contours and crepitations, any abnormal movement in the mandible and abnormal mobility in the maxilla. So this completes the examination of a quick examination of a maxillofacial injury patient in the ED. Thank you.
Thank you. Now, any question from the audience? Suppose the patient of faciomyography is need the rhizome insertion. Very simple. From where you will put rhizome? That's that. Yeah. Okay. Thank you.